Welcome to the Explainer. All right, let's dive right into this because we've got a lot of ground to cover. Today, we're running an advanced clinical review focusing on hepatic and infectious diseases. We're going high energy, rapid fire, zero pauses. So lock in and let's master these clinical concepts together.
Section 1, TB Drug Toxicity Profiles, First-Line Agents.
Okay, question 1. Which of the following antituberculous drugs is the most hepatotoxic and most commonly associated with severe, prolonged, drug-induced hepatitis? Is it A. ethambutol, B. rifampicin, C. erythromycin, D. ciprofloxacin, or E. pyrazinamide? If you guessed E. pyrazinamide, you are absolutely right. Here's the reason. Pyrazinamide is literally the most hepatotoxic first-line antituberculous drug out there. We're talking about a hepatotoxicity incidence rate ranging from 10 to 20%. It causes this severe, dose-dependent, direct hepatocellular injury, plus an idiosyncratic immune-mediated necrosis. So it easily ranks #1 for hepatotoxicity, meaning you've got to have strict baseline and serial liver function test monitoring. Absolutely crucial.
Let's keep moving. Question 12. Which of the following antitubercular drugs causes peripheral neuropathy? A. Isoniazid, B. rifampin, C. pyrazinamide, D. ethambutol, or E. streptomycin? The correct answer here is A. Isoniazid. Why? Because isoniazid actually promotes the excretion of pyridoxine, that's vitamin B6, and that can lead to a deficiency that manifests clinically as a really painful peripheral neuropathy. All right, time for some rapid-fire exam pearls on core INH adverse reactions. Number 1, dose-dependent peripheral neuropathy. Number 2, idiosyncratic hypotoxicity. Number 3, drug-induced lupus erythematosus. And number 4, seizures and general central nervous system excitability.
Section 2. Hydatid cyst clinical management, surgical and medical interventions.
Question 2. Which of the following surgical interventions is most commonly employed for the definitive treatment of a hepatic hydatid cyst, specifically with the highest success rate and lowest risk of structural recurrence? A. Steroid administration with epinephrine. B. Excision of cyst. C. Primary medical treatment with albendazole alone. D. Percutaneous catheter drainage, also known as PAIR therapy. Or E. Primary medical treatment with metronidazole. The answer is B. Excision of the cyst. Surgical excision via a total paracystectomy is definitely the gold standard therapy here. It achieves complete source control by removing the entire host-derived adventitial layer right along with the parasite's laminated and germinal layers, all without actually opening the cyst. Let's hit the exam pearls for anatomical structure. You've got the paracyst, which is the host's inflammatory fibrous tissue, the ectocyst, which is the parasite's laminated membrane, and the endocyst, the vital germinal layer that actually generates the protosclerosis. So, in surgical terminology, a total paracystectomy means the complete removal of all 3 of those layers without ever entering the cavity.
On to question 3. A 26-year-old male from a rural farming village presents with vague right-sided lower chest pain. No cough, no night sweats, no evening rise of temperature. A chest x-ray reveals a 2 by 3 centimeter smooth, rounded, calcified mass located in the right lower zone of the lung. So, what's the most likely diagnosis? A. Tuberculoma, B. Aspergilloma, C. Hydatid cyst, D. Pulmonary sarcoidosis, or E. Histoplasmosis. The answer is C. Hydatid cyst. Look at the clues. The rural farming demographic and that total absence of systemic constitutional signs, like fever or chronic cough, really point away from TB. Instead, it points perfectly toward an uncomplicated pulmonary hydatid cyst presenting as this silent calcified mass. Exam pearls. The transmission cycle involves dogs as definitive hosts, and humans are just accidental dead-end hosts. Radiographic signs to watch for? The meniscus sign, which is a radiolucent air crescent telling you a rupture is impending, and the water lily sign, which means you've got a collapsed endocyst membrane just floating freely in there.
Next up, question 4. A young female from a sheep farming district presents with a gradually enlarging, painful right upper quadrant mass. Physical findings suggest a liver swelling. An ultrasound shows a space-occupying mass of about 6 by 5 centimeters with multiple freely floating echogenicity. What are we looking at? A. Hepatic cavernous hemangioma. B. Hepatic hydatid cyst. C. Cholangiocarcinoma. D. Liver abscess. Or E. Renal cell carcinoma. It's B. Hepatic hydatid cyst. The sheep farming background, paired with those ultrasound findings of freely floating echogenicity,
That's what we call hydatid sand, and it's an absolutely classic presentation. Diagnostic exam pearls, nonspecific eosinophilia is super common. Serology via ELISA will confirm your diagnosis. Ultrasound is incredibly sensitive for double line wall signs and that hydatid sand. CT scan is your gold standard for anatomical staging. And ERCP, that is strictly indicated only when the cyst communicates with a biliary tree.
Question 5. Which treatment option is best for a multiloculated hepatic hydatid cyst measuring 6 by 11 centimeters? A. Surgical excision. B. Paratherapy. C. Immunotherapy. D. Serial ultrasound examination. Or E. Medical treatment with albendazole only. The answer is A. Surgical excision. Here's the deal. According to the WHO ultrasound classification, a multiseptate honeycomb cyst is classed as CE2. Paratherapy is strictly contraindicated here. Why? Because those internal septa completely prevent adequate aspiration, and they actually shield the daughter cysts. You really need to familiarize yourself with the exact structural stages and guidelines of that WHO ultrasound classification.
Question 6. Now, what's the preferred treatment option for a hepatic hydatid cyst that is active, unilocular, and measures 7 by 11 centimeters? A. Surgical excision. B. Paratherapy. C. Immunotherapy. D. Serial ultrasound examination. Or E. Medical treatment with albendazole only. For this one, it's B. Paratherapy. This perfectly matches WHO class CE1. Paratherapy has an exceptionally high success rate here simply because it lacks those internal septations we just talked about. Exam pearls for paratherapy. Absolute contraindications include inaccessible pathways, multiseptate CE2 cysts, fully calcified CE5 cysts, and any cystobiliary communication. Oh, and for anaphylaxis prevention, you must always have perioperative steroids and epinephrine on hand. No exceptions.
Question 7. Which of the following is preferred for initial medical treatment to prevent recurrence and to manage established recurrent hydatid cyst disease? A. Albendazole. B. Mebendazole. C. Paratherapy. D. Steroid therapy. E. Metronidazole. The correct answer is A. Albendazole. Albendazole is your first-line medical agent because it has excellent tissue penetration. You start it 1 week before surgery and continue it up to 3 months post-surgery. Pharmacotherapy pearls. Mebendazole has mostly been abandoned due to poor intracystic absorption. Also, for surgical field protection, you've got to pack the field with pads soaked in potent scolicidal agents. Think hypertonic saline or ceramide.
Section 3. Tropical and lymphatic infections, filariasis and enteric fever.
Question 8. Which of the following drugs is used for management of lymphedema secondary to Wuchereria bancrofti infection? A. Albendazole. B. Mebendazole. C. Diethylcarbamazine. D. Ivermectin. Or E. Praziquantel. The correct answer is C. Diethylcarbamazine, or DEC. DEC is highly effective in the early stages of secondary lymphedema, way before those gross, irreversible fibrous deformities have a chance to develop. The mechanism exam pearl here is that DEC exerts a really potent microfilaricidal action. It clears out circulating larvae and halts that progressive lymphatic structural obstruction.
All right, a longer clinical vignette for question 10. A 28-year-old male presents to a regional health center complaining of black tarry stools for the past day. He gives a history of a high-grade fever for the past 2 weeks. On exam, the guy appears toxic. Pulse is 83 per minute, blood pressure 90/60, respiratory rate 25, and temp is 102 degrees Fahrenheit. Lab analysis shows a leukocyte count of 4,000. No past history of parectal bleeding, and a colonoscopy shows no abnormal findings. So what is the likely cause of his toxemia and bleeding per rectum? A. Solitary rectal ulcer syndrome. B. Crohn's disease. C. Ulcerative colitis. D. Amoebic colitis. Or E. Typhoid ulcer.
The answer is E. Typhoid ulcer. Here's the breakdown. A prolonged 2-week fever, systemic toxemia, relative bradycardia, and leukopenia. That is a textbook presentation of typhoid fever caused by Salmonella typhi. When enteric fever is severe and untreated, it leads straight to necrosis of Peyer's patches in the terminal ileum. Let's lock in those typhoid exam pearls. The pathological landmark is selective hyperplasia followed by necrosis of the ileal Peyer's patches. For your clinical mnemonic, always look for that triad: relative bradycardia, a step-ladder fever profile, and leukopenia on the CBC.
Section 4, GI surgical pathologies, complications and obstructions.
Question 9. A 39-year-old male was discharged following an open appendectomy for a ruptured appendix. A few days later, he comes back with a fever, a raised white cell count, and a non-tender swelling at the wound site containing multiple sinuses and foul-smelling discharge. He's put on antibiotics, but there's zero clinical improvement. What's your diagnosis? A. Intra-abdominal abscess formation. B. Wound dehiscence. C. Actinomycosis. D. Staphylococcal surgical site infection. Or E. None of the above?
The correct answer is C. Actinomycosis. Developing a hard, woody mass with multiple indurated, tracking sinus tracts several weeks after a perforated appendicitis? That is the classic presentation of abdominal actinomycosis. It's caused by Actinomyces israeli, which is an anaerobic, gram-positive filamentous bacterium. Actinomycosis, exam pearls coming right up. Pathology. The infection tracks right through tissue barriers, forming abscesses that discharge pus filled with characteristic yellow sulfur granules. Clinical appearance. The overlying skin often takes on a dusky purplish hue. Anatomical subtypes. The most common ones are cervical fascial, thoracic, ileocecal, and liver. And for management, you're going to need long-term, high-dose penicillin G and potentially some surgical debulking. Question 11. Fibrosis and bands occur in the gut due to which of the following diseases? A. Typhoid. B. Tuberculosis. C. Ulcerative colitis. D. Acute ischemic colitis. Or E. Amoebic colitis. The correct answer is B. Tuberculosis. Intestinal tuberculosis classically targets the ileocecal region. It forms these transverse ulcers that heal via massive fibrosis and strictures, effectively pulling the cecum up into a subhepatic position. Exam pearls for macroscopic variants. The ulcerative form usually leads to strictures and small bowel obstruction. The hyperplastic form, on the other hand, mimics an ileocecal mass or carcinoma.
Question 13, our final scenario. A 12-year-old boy presents to the ER with abdominal pain, vomiting, and distension. You diagnose acute intestinal obstruction. A conservative trial, nasogastric tube, resuscitation, hypertonic saline enemas, has completely failed. On laparotomy, you find a bunch of roundworms occluding the lumen and causing the obstruction. What is your next step? A. Milking of worms down the ileocecal valve. B. Enterotomy and removal of worms. C. Closure of the abdomen and anti-roundworm medication. D. Normal saline enema. E. Resection and anastomosis.
The answer is A. Milking of worms down the ileocecal valve. Why? Because when an impacted bolus of Ascaris worms causes an obstruction, but the underlying bowel wall itself is still healthy, your first-line intraoperative maneuver should always be to just gently milk that worm mass across the ileocecal valve and into the large intestine. Here are your surgical step escalation pearls for ascariasis. Step 1. If the bowel is viable, attempt to milk the mass into the colon. Step 2. If milking fails but the bowel is still viable, then you perform a longitudinal enterotomy. Step 3. If the bowel is perforated or gangrenous, perform a formal segmental bowel resection. But crucially, no primary anastomosis here. You manage it with exteriorization instead. Also, keep in mind the trigger mechanism. This is often caused by anthelmintic treatment leading to a rapid die-off and an impacted bolus. Master the fundamentals, trust the clinical presentation, and always anticipate the complication. Think about it. If a simple roundworm can trigger a massive surgical emergency, what other silent pathogens are just hiding out there in plain sight? Keep reviewing, stay sharp, and we'll see you in the next explainer.